Thanks again for joining us, everybody, and for telling us where you're at. This is great to see everybody joining us from around the nation. We are about to start our virtual forum on how the justice system and addiction treatment are tackling overdose deaths. You know, just looking at the current events reminds us how important today's topic is. Just yesterday, we saw research citing that police drug busts are strongly associated with a large and sudden spike in overdose deaths. And then at the other end of the spectrum, I know that Ohio is one of 8 states that have seen a decrease in overdose deaths, and nationally, the number of deaths is slowing its increase. So we're making progress, but we obviously have much left to do. A few housekeeping notes before we get started. Please feel free to ask any questions via the chat. We will answer those at the end. And we will also be providing you links to the slides and a certificate of completion at the end of this presentation. We have assembled an amazing panel of experts to unpack this topic for you. I'm very excited about it. Our main presenter is Emily Harsh. She's Brightview's Director of Justice System Outreach. She's been with Brightview since 2018, and her efforts have been critical to our ongoing collaboration with law enforcement. Joining Emily is Jenna Cropper. She's Brightview's Vice President of Laboratory Services. Jenna oversees laboratory personnel and services across all of our locations, and she has a background operating lab and compliance divisions in previous roles. And to round out the panel, we have John Inman. He is Brightview's Associate General Counsel and Director of Government Affairs. John assists in all Brightview legal matters and coordinates with government agencies at the federal, state, and local levels. And in addition to previous healthcare experience, John's also served in law enforcement. And with that, I will hand it off to Emily.
Thank you. And thank you to everybody for joining us today. I have had the pleasure of meeting with quite a few of our partners over the past few years. And my main goal for this forum is not only to share some education around how Brightview is addressing overdoses in our communities, but also just to address some common questions that we've received from you all, specifically around our lab services. I'm really excited to be sharing the floor with Jenna and John. They're both a wealth of knowledge in their specialties, so please share any questions you might have in the chat box below, and we'll do our best to address them in the Q&A at the end. I'd also like to take this opportunity to extend an open invitation to all of our partners on the forum today to come down and tour any of our locations. If you're interested in scheduling a tour or learning more about partnering with Brightview, please put your name, role, city, and state in the chat box, and a community outreach manager will be in contact to schedule following today's forum. All right, so we're just going to go ahead and get started with a brief refresher on substance use disorders. If you have attended any of our forums in the past, I think we've gone into length quite a bit in the past, so we're just going to do a quick refresher today. The main things I want to point out here is that addiction is primary and chronic. Those are the two main things I like to highlight. Primary meaning that it is its own disease with its own biology. Chronic meaning that it's ongoing, and most individuals experiencing addiction do require some level of ongoing care following stabilization. Use disorder, there are 11 criteria that we're looking at. You only really need about 2. You only need 2 of them to qualify for a use disorder. So I think that's something that is a little bit it's a little bit enlightening for a lot of people to hear. When you think of somebody having a substance use disorder, often you're thinking of somebody who is deep into addiction, somebody whose life has spiraled out of control. And you really only need 2 of these criteria we're going to go over to qualify for a use disorder. Some of the things we're looking at with our patients are substances being taken in larger amounts over a longer period than intended. Have they tried to reduce or control substance use in the past and been unsuccessful? Have they spent a lot of time engaging, obtaining, or using, or recovering from the effects of substances? Are there cravings? Are they continuing to use even when it causes issues, even when they are failing to fulfill role obligations? Continuing to use in situations where it's physically hazardous? Have they developed a tolerance experiencing withdrawal? Like I said, only 2 of those criteria need to be met to qualify for a use disorder. Next slide, please.
So What we want to look at here is the likelihood of an overdose after reentry into the community. There's some statistics there on your screen. I think they're pretty staggering. More than 600,000 incarcerated individuals leave prison. More than 7 million leave county jails. 85% of those have an active substance use disorder and were incarcerated for a crime involving drugs. The most important thing I think that we need to look at in this slide is the 75% of individuals recently released from incarceration with SUD report a relapse within the first 90 days. This is critical. From my time in law enforcement, this is the most dangerous time for someone when they've just been released from incarceration. They have been in a different environment. They go back to most likely their old environment that contributed to what led them to having a substance use disorder diagnosis. And their tolerance is lower. But I would see a lot of these, unfortunately, it's my time as a police officer, and it was devastating. It devastated the community, and it was really difficult. And those individuals are at a very, very high risk of that overdose and returning back to their substance use within that short period of time. Go ahead to the next slide.
All right, so for this next slide, it was really important that, at least to me, that I think that we take some time and get to understand a patient experience. And I want to stress this is a fictional patient. I've had the pleasure of working with probably hundreds of patients over my time at Brightview, and I didn't take any of these beats from any specific patient. This is just kind of a general story I was able to come together with being in drug courts, being in our centers, and hearing firsthand all of the barriers our patients face. So I'm going to take you through a fictional patient, Steve. I'm going to take you through step by step, and honestly, this breaks my cardinal rule of presenting too. I'm actually going to read from a slide, so bear with me, and we're going to learn a little bit more about Steve. The most important thing that I think I want you guys to keep in mind is that most people, like Steve, don't just wake up one day and decide they want to become addicted to drugs. They're fathers, mothers, sons, daughters, sisters, brothers, aunties, and uncles before they even touch a mood-altering substance. And they continue to be all those things. And I know compassion burnout and fatigue is so high in our field. So I always just try to take every opportunity I can just to kind of remind everybody. Because you guys do see our patients through some of the worst times of their lives. So let's learn a little bit more about Steve. Steve was raised by his grandmother after his mother died from an overdose when he was 2. His father was never in the picture. As he grows older, so does his grandmother, and in his early teens, he finds himself becoming her primary caregiver. When Steve was 17, he was in a serious car accident on his way home from a football game. He had multiple fractures and had to have emergency surgery. Things were touch and go for a while, but he finally recovered full use of his legs and continued to live with chronic pain. Steve graduates high school, starts a course at a community college to become a nurse. He always enjoyed caring for his grandma, and with his recent experience going through physical therapy, he was inspired to start his career in nursing. Over the next few years, Steve continued to care for his grandma and started working as a nurse aide at a retirement community. Steve loves his job and is doing pretty well in his classes, but the physical demands of lifting and transporting his residents alongside chronic pains from his injuries just becomes too much for him to manage. His grandma sees him in pain and occasionally gives him some of her pain medication over the next few years. Steve starts to realize he likes the way this medication makes him feel, and if his grandma takes it, he thinks it couldn't be too bad for him to use once in a while. Eventually, Steve starts buying Percocet from a friend of a friend. Over the next year, his body becomes physically dependent on opiates, and he starts buying Xanax and drinking to manage his symptoms of withdrawal. He knows things are getting out of control. He knows he needs to stop, but he doesn't know what to do. After he witnesses a friend overdosing, he starts making calls to try to get into treatment. He doesn't want to end up like his mother or his friend. On his lunch break, Steve calls a local treatment provider, but he's told they don't accept Medicaid. The only insurance he has access to as a low-income student is Medicaid. He makes a few calls and finally finds a provider that accepts his insurance, and he's told he can come in for an assessment anytime, but he'll need to wait for a call back to actually start their services until he reaches the top of their wait list. A few days later, Steve's life spins out of control when he's arrested for possession of a controlled substance. He immediately loses his job at the retirement community he's worked for since he was 19. And he's devastated. Aside from his grandma, the patients he cares for and his coworkers have become the last piece of stability in his life. He feels ashamed now that everyone knows his secret. Steve starts a drug court program that refers him to one of their contracted providers, and for the first time in years, he starts to feel better. Through the support of the court and his treatment provider, he reconnects with his former boss at the retirement community. They put in a good word and they get him into the dining services, and they get him a position in the kitchen. Since he's in drug court, he can't be patient-facing, but he's just excited to be back working with his patients, and he hopes that he can resume work as a nursing aide soon. After years of being stuck in a cycle of addiction, he starts to feel alive again. He's making good money, attending his counseling sessions. He's found a sense of community and connecting with people who are going through the same thing as him. And for the first time in years, he starts to feel like he's not alone. Another few months go by, and Steve's progressed through intensive outpatient treatment and has graduated to outpatient care with his treatment provider. Steve keeps making the next right choice in his life until one night, a coworker invites him to a party. At this point, he's had about 9 months of counseling. He knows that's not a good environment for him to be in right now. But in a moment of weakness, he goes anyway. And at the party, he makes a few not so great choices, uses alcohol and uses cannabis. And he knows this violates his probation and the terms of his drug court program. But in his mind, he's rationalizing it because he's never really had an issue with alcohol or cannabis. A few days later, Steve goes to his next counseling appointment and is honest with his therapist about his recent use. He identifies justifying alcohol and cannabis use as an outlet to quote unquote have fun was not a healthy choice, and he works with his therapist to explore new ideas for hobbies that would better support his sober lifestyle. Steve then calls his probation officer and lets them know what happened. He's honest with his use, and he's not surprised, and neither is the court surprised when his next toxicology tests positive for alcohol and cannabis. The judge presiding over his drug court treatment program sanctions him for violating the terms of his probation, and once again he's sentenced to 30 days incarceration. He goes to jail, goes through the cycle of losing his job again, and unfortunately, while he's in jail, his grandmother passes away. Upon re-entry, he learns that he's also been discharged from his treatment provider since he hasn't been able to attend those meetings while incarcerated. Steve is hopeless and overcome with grief. He turns back to the only thing he's really known, relapses, overdose, and is rearrested again within 2 weeks of release. So I know that was quite a long-winded story, but all of these beats, I can't stress enough, these are real barriers that every single individual working through recovery from addiction is facing. It's not just one area of their life. When their life implodes to a point where they're involved in a drug court, or they're working with our justice system partners, there's a lot of pieces to pick up. All right, next slide.
Thank you, Emily, for that overview. When we're speaking in terms of addiction, I think it's important to start with some fundamental concepts before jumping too far into the weeds. So addiction is a chronic neurobiological disease. And when looking at that disease, there's two different aspects that are very important to understand, and that's the pharmacological and the psychosocial aspects, which are both seated and rooted in the human brain. In the human brain, we have what are called neurons. Those neurons have a presynaptic and postsynaptic neuron aspect to them, where neurotransmitters are submitted from the presynaptic to a receptor on the postsynaptic. For example, opioids. Opioids travel through the brain through two different pathways, the pain pathway and the reward pathway. When the opioid travels through the reward pathway, it releases what is called dopamine. That high influx of dopamine is received at the receptor, creating what is a high or a positive reward in the human brain. In order to treat that addiction, we utilize a few different types of medication. Buprenorphine, naloxone, naltrexone, all of which have various medical terminology associated with them, but each acts on the receptor as either an agonist, partial agonist, or an antagonist. So opioids, when they are received at the receptor and medication is introduced, that medication, such as buprenorphine, has a higher affinity for attaching to the receptor and knocks the opioid off. Buprenorphine acts as a partial agonist to give some of that high effect, but also to treat the symptoms associated with addiction. Antagonists, such as naltrexone, also has a higher affinity than the parent drug and turns off the receptor completely. Next slide, please. So with having that basic understanding going into this conversation, many of our patients are subject to stigma. Stigma is a negative connotation associated to something, whether that something is a quality, a characteristic, a personal experience, circumstances, their environments, whatever that may be. And when introduced to those stigmas, it's very damaging to their perception of themselves and how they perceive where they're tracking. And so we need to start changing the language around, how do we change the setting of care and the environment in which our patients are seeking care. Next slide, please. So how are these stigmas dangerous? Our patients often do not disclose their previous substance use problems. They don't feel safe. It feels like a punitive environment. They feel like they'll be reprimanded. It doesn't feel like an environment that promotes a culture of being able to come forward with where they're struggling, which is, a huge deterrent in their journey to recovery. So many of them go to a primary care facility, seeking out just the first steps of addiction. And many of those primary care providers lack the understanding, experience, and education required to help facilitate and aid in success, especially in these given patient populations, many of which have very challenging behaviors associated with addiction that are sourced from either maladaptive behaviors, co-occurring disorders. You can imagine schizophrenia can oftentimes come with manic behaviors that present themselves, especially under stressful times when they're going through recovery. Looking at acute and post-acute withdrawal symptoms. You can imagine starting your journey to recovery and going through withdrawal. Oftentimes these patients are very sick and struggling to just get through that initial hurdle. And with that, it's presenting behaviors that would not be idealistic. And they're reacting in that. Many of our patients, understanding that, the road to recovery, it isn't a linear process. These are each individuals with variable histories, environments, backgrounds. It's very dynamic. You can't place one system in place and think it's going to be successful. Sometimes you often hear people saying, I just got on this medication, I need some time to adjust, or I need to go back to my provider. And we need to have that conversation of how we adjust our dosing or looking at different medication options. And so with all of that, understanding that during an opioid crisis and an overdose crisis, that getting this therapeutic aspect, this therapeutic alliance aspect in place to promote the overall and general well-being and recovery is essential. Providing an atmosphere that's comfortable where we can have these open conversations with our providers and our caregivers. So looking at aspects of, Brightview as a whole and what we can offer is that we have this understanding of these behaviors and how to treat and approach it so that we can create an environment where they can be open and honest, and we can help to adequately treat the patient as a whole, both pharmacologically and psychosocially. Next slide, please. Over to you, John.
Okay. This is a little bit out of my area. To go back, can we go back for a slide real quick, just for a comment on the stigma? I think this is especially important in the criminal justice system, about the stigma, as it influences the view of the prosecutors, the judges, defense attorneys as well, not only healthcare providers, because from my experience, it's looked at as a choice. So a lot of the court system and a lot of those folks involved looked at, addiction as a choice, is that you can just overcome it or you can choose not to use it. And I think that they ignore the effect that the substances have on the brain and the ability of the individual to make correct choices, and to choose to be sober, or some even view it as initially, if you're using a substance like the example that Emily gave for Steve, it felt good or it makes you feel good. But what they fail to see is that it's really a maintenance over time. It's just so that this person doesn't want to feel ill or whatever it is. And I think that the criminal justice system, really looks at that way. Because in American criminal law, you have two elements. You have the actual act of the crime and the mental element. And I think that we're just now starting to discover, by reducing this stigma, that the mental element is not present in these crimes, so that we're able to get these individuals, that have been involved in some sort of crime because of their addiction, some leniency from the court because of that. But it's been a long road. I mean, it was really present when I was in law enforcement and I was involved in being in the criminal justice system. But I think that, because of education and a lot of actions on behalf of advocates and providers and everyone else, that we're slowly seeing that migration towards understanding and reducing that stigma. So we can go ahead and advance on that. Sorry. But again, the treatment for the buprenorphine, I mean, you can read the slide there, but as far as the stigma, and the MAT, one of the things that we have to look at is that I think in the criminal justice system, and I've heard this from a few people, that, you're substituting one drug for another. And that's not necessarily true, because of the effects of buprenorphine and even methadone. It doesn't allow a person to get, what you would call high or intoxicated on the drug. It simply abates those physical symptoms that the person has and allows them to continue on in their treatment without being literally physically ill and sick. So the length of time on that medication, obviously, is dependent upon the individual, but I think that that's one of the big things about the stigma that everyone needs to realize is it's not, substituting, it's just combating the physical symptoms of addiction so that the person can continue on their recovery without that feeling of sickness or illness or the actual physical desire to ingest that drug.
Absolutely. And I can't echo John enough when it comes to that. I don't want to speak too much out of my scope of practice. I'm a counselor, not a medical provider, definitely don't want to go to medical school that long. But I do feel confident in kind of breaking down some of these criteria that for policy we're looking at when we have an individual that is interested in tapering. I think it's really important to look at the motivation for tapering. When I've been a counselor with Brightview in the past, I've had a lot of conversations with our patients where they come into our room, we start the session, and they're like, look, I got to taper to get off probation. I got to get off this medication to get my kids back, or I got to get off this medication to graduate drug court. And typically that, as a clinical provider, as medical providers, those aren't necessarily criteria that we're looking at that indicate the most success on somebody tapering off a medication. So what we're looking at is both internal and external factors motivating them. that they have been stable on this medication for a good amount of time. When I say a good amount of time, most individuals that have successful tapers, we're not talking about 30, 60, 90 days, 6 months. We're talking about a good chunk of time that helps support them in getting all areas of their life back on track. We're also looking at their employment, their social situations they're in, their housing, their cognitive abilities, their engagement in treatment, and most importantly is their engagement outside of our four walls at Brightview with sober support, with community mutual help programs. These are all the factors that note that somebody is on the right track for a successful decrease or a successful taper off. And when we're also looking at that, we're thinking about a plan. This isn't a medication. Typically, these medications aren't something that we can just have a 2-week taper plan on. It is really something that is individualized per every patient, and it's a plan that's worked on with a provider and the patient at the center of it, really with the patient at the center of it. So I know I've gotten a lot of questions over the years from partners, and I've gotten a lot of feedback from patients. Having external motivation to come off this medication, trying to get off probation, parole, drug court, things like that. So I always just try to provide a little bit of additional education around this piece, because this is not a medication that enables our patients, or it's not trading one drug for another. It truly is treating the disease of addiction in the brain at a level that can help stabilize them, so we can work on the counseling interventions and they can make the strides they need to be the person they want to be. Next slide. So this next section, we're just going to go over some of the policies and practices we have in place at Brightview that really helps us address the rates of overdose in our communities. The biggest one here I want to highlight is focusing on increasing average length of stay and patient retention. We know that addiction is a chronic relapsing disease for many of the patients we serve, and keeping our patients engaged in clinical services is the most important thing I think we do, because we know that we can treat the brain, we know that we can stabilize medically, but honestly, groups, clinical services, that's the meat and potatoes of our care right here. That's where we see people get their confidence back, get their joy back. They start to feel like people again. And I have to say, it's the most beautiful thing to be able to watch. We also strive to make the process of getting started in our services as easy as possible. Not only getting started initially, but starting again. A lot of times I do hear some talk in the community just about how some addiction treatment can be like a revolving door. And I like to kind of push back against that. I think if it's a revolving door, we should celebrate the people that are taking the steps to try again. Even if it's their 10th, 15th, 20th attempt, that's still somebody who's trying, and that's still somebody who's fighting against the disease of addiction. And we celebrate every time they walk into our doors. A couple other policies I really want to highlight here, non-punitive policies for our patient care. When it's clear that somebody is not getting what they need from outpatient services or even IOP services at Brightview, that's an ongoing conversation we have. We found that you really can't have good outcomes if you're giving somebody an ultimatum. So we use a lot of solution-focused interventions. We use a lot of motivational interviewing to keep individuals who need a higher level of care engaged until that higher level of care is available. Because often we're dealing with external barriers as well. So this could be waiting for a bed to become available. This could be a whole different host of things. Maybe they want to go to residential, but they need childcare, or they need to apply for FMLA. There could be a lot of barriers in getting that next level of care. So we have these conversations, and it's an ongoing discussion to really help focus and help them with a plan that's going to help them transition without disrupting their lives. We also understand that some level of engagement in services is better than none. So I think you can really break this down to any disease and any treatment plan somebody might have for a disease. I would say most patients across all fields of medicine don't follow their treatment plan to a T. I know I'm about 4 months late on a dental cleanup, so I feel comfortable saying that when it comes down to it, we don't always follow our treatment plans to a T. But not every healthcare arena kicks their patients out for not following their treatment plan. And I think that's another thing that we need to really focus on, is that, you know, our policies should encourage our patients to attend their counseling sessions. We hold them accountable through our re-engagement program, which I'm really excited to share about. I think that's on the next slide. I'll touch base on that a little bit as well. I'm going to jump around a bit since I already started talking about our re-engagement program. This is something that we started, I think, back in 2018 or 2019. We really started tracking our patients that were starting to slip in attendance to clinical services. And what we found is that we run a report every morning, and it highlights all of the patients that are due to come in for medical, and it highlights the ones specifically that have not attended clinical sessions, that are starting to slip in their attendance. And what we're able to do, instead of having a punitive slap on the wrist conversation, they're flagged by our front desk staff. We coordinate with our clinical staff, and we have a clinical staff member meet with them before their medical appointment. And these conversations are solution focused. And they were one of my favorite things to do as a clinical provider, because usually at the end of that session, we're walking out with a game plan. We're walking out with somebody who has access to transportation services if that's their barrier, or has an application for childcare services through their county if that's their main barrier. It really is not, like, I can't stress enough, it's not a slap on the wrist, it's not a punitive discussion, it's a really solution-focused discussion that helps us understand the barriers our patients are facing and figure out how we can get them to increase their level of engagement in clinical services. Another one of the things that we offer at every medical interaction is a prescription for naloxone or Narcan. This is another example of how evidence-based practices informs our policy, but I really want to take a second to break this down a little bit, because I know that there is a lot of stigma and misinformation around naloxone, and I've definitely had more than a few questions around these kind of policies from our partners. So with the state of the opioid epidemic and the level of fentanyl impacting our communities, it's really vital for everybody to have access to Narcan, not just individuals who are utilizing substances, not just individuals who live in areas that are perceived as having high drug activity. I truly believe every person should have Narcan on their body all the time. You never know when you're going to run into somebody at the gas station, on the corner, at the dollar store. Just with the level of fentanyl impacting our communities, it is such a valuable first aid resource to have. And when it comes down to it, we can't welcome our patients into our centers and support them on a path of recovery if they don't survive their overdoses. So if anybody's here is interested in learning more about Narcan or how to respond to an overdose, most local health departments also offer training to their county residents on how to respond to an overdose. The last piece I really want to focus on is just our policies around immediacy of care. So we have a couple different pathways if somebody is looking to get started at Brightview. Our easiest one is probably our 24/7 patient access call center. So any time of day, 24/7, somebody can call and want to get services started at Brightview and talk to somebody, like not a recording, but an actual person that can help them through that process. And I think that's really important, because I've had my own experience trying to schedule doctor's appointments, obviously that dental appointment I was talking about. And if they would just pick up the phone or have an online scheduling tool, it's so much easier to participate in your own care. So I think that's really a barrier-free way for somebody to just get services started. We have to be ready when they're ready for treatment, even if that's 3 o'clock in the morning and they just saw a friend overdose and they're like, hey, I really need to call Brightview. I need to get in tomorrow. We're here to pick up the phones. We also have walk-in hours. The majority of our locations have walk-in hours Monday through Friday, 8 to 3, and we encourage walk-ins. I think the most important thing about being a treatment provider in this day and age is being ready when our population's ready. So a lot of them don't necessarily have the ability or the skill or the resources to call into our call center. They might not even have a phone. They can walk in through our doors and be seen for assessment by a medical provider and a clinical provider day one, no wait list. We pretty much have unlimited capability when it comes to that. We also have our online scheduling tool, which I definitely want to highlight, especially from a partner perspective. If you have an individual you're working with, say they're on probation or parole, or they're a member of your drug treatment court, I think it could be really helpful to increase our coordination of care and make sure not only are our patients getting everything they need, but our partners are able to collaborate and we're able to advocate for our patients. So to that end, scheduling through our online scheduling tool helps us identify as having an individual who is linked to a probation officer, and doing an online release of information when you're sending us the referral or when that patient is scheduling helps us identify that this is an individual that
If you like, just go ahead to the next slide and I'll jump in. There we go. So we'll get into the drug testing aspect of what it is that what we do here at Brightview and how that plays into the success of our patients in their recovery journey and how we treat addiction as a whole. So as I had mentioned before, it's a pharmacological and psychosocial treatment program approach that we take to treat the whole individual. And with that, drug testing plays an important part of that and many of the different dynamic aspects. So identification, diagnosis, treatment, and the promotion of recovery for our patients and patients at risk for addiction. So to break these down a little bit further and just give you a little background on the scientific aspect, identification, we utilize immunoanalysis and liquid chromatography mass spectroscopy in order to look at the different drugs, drug classes, parent drugs, and metabolites within the specimen and a given window of detection. To give a little bit of like a nuance definition of some of these things, we utilize screen testing, which is also considered presumptive. And we also use confirmation, which is definitive. And why are those two different aspects so important to understand? So on screen testing, there are oftentimes a lot of interferences on our instrumentation due to, synthetic drug makeup. And we often refer over to confirmatory, where we're able to give an exact quantification of how much drug is within the system at that given time. And why is that so important in identification, right? So looking at confirmation testing, we can actually quantify both the parent and the metabolic outputs of that parent drug. Morphine is the active ingredient that makes its way to the human brain to turn on the dopamine receptors. And morphine can be a derivative or a metabolite of a few different drugs. So for example, codeine and heroin, both are parent drugs that metabolize into morphine. Heroin breaks down into 6-monoacetylmorphine, which is an intermediary that we can actually detect on the instrumentation, where codeine has no intermediary and breaks straight down into morphine. So by looking at the metabolic pathway, we can determine where the parent drug was derived from. This testing is also important in looking at the metabolic systems in that when we're treating our patients with buprenorphine, many of them who are not taking their prescription drugs will, when they're being tested, take some of that buprenorphine, sprinkle it in their specimen, and send it off to the lab. If we do not see the metabolite nor buprenorphine, we can kind of allude to the fact that there was perhaps some spiking in the specimen that was produced for testing and that they may not be taking their medications appropriately. The diagnosis. So drug testing alone cannot diagnose substance use disorder. We have to look at a variety of modalities to attain that, such as looking at DAST, audit DSM-5 diagnostic tools in conjunction with the drug screening and testing. Many times these results come in through what is called a window of detection. So, for example, alcohol is only detectable for urinalysis for up to 24 hours, whereas the metabolites can be active in the system in red for up to 48 hours. So we have to understand that taking the different aspects of the pharmacological and the psychosocial and utilizing them in combination to be able to diagnose. And also to create treatment plans. Toxicology and pharmacology have two different dynamic aspects called pharmacokinetics and pharmacodynamics that looks at the absorption, distribution, metabolism, and elimination of drugs within the human body, and understanding the bioavailability, biotransformation, dose response, and tolerance to be able to quantify and look at what is the best treatment plan for these patients in those regards. Lastly, promotion of recovery. And I think this is the most important in terms of this conversation. Looking at contingency management. You could imagine going back to Emily's initial story of Steve, where, you know, he's gone through this struggle of addiction, he's seeking care, and he's being given a report that shows his inconsistent results. Over time, he's been taking his medication appropriately, and he starts to see consistency across the board, where it's expected that he is taking his medication appropriately, and there is no illicit use of substances. That alone can create positive reinforcer in the brain, much like the dopamine pathway, to help filling in that void. Go back to like when you were in school, right? Say you were in a mathematics class and you were failing. You sought out a tutor, you got appropriate help, and you started getting A's. That's a great feeling, and that's a great feeling for our patients. And that's helping to create that therapeutic alliance that we're looking to generate so that they feel comfortable in this space. With that therapeutic alliance, these toxicology reports also help to act as an objective piece of data. Many of our providers, it helps to take off that detector role and place that on the toxicology report. Again, addiction treatment is not linear, it is variable. There are some times where there will be unexpected results in a positive illicit drug. And to be able to have the conversations with our patients, to be able to continue the conversation of how can we help? What is there that we can do to help bring you to a state of sobriety? Let's be honest, have an open conversation and not a punitive conversation. And so these reports help to act and facilitate in that way, and taking that off of the provider. A few aspects here in terms of the toxicology reports. We utilize liquid chromatography, mass spectroscopy for our confirmatory testing. ASAM, they consider this to be the gold standard. It is a quantitative test that is 99% accurate to looking at parent and metabolites within the system in a given window of time. These tests are ran based off of the patient specimens that are submitted to our laboratory. Those are dictated by medical necessity from our providers. We're able to analyze for over 60 parent and metabolic drugs within the system. And we also utilize what's called a validity test, ensuring that the specimen hasn't been tampered with. We utilize creatinine. Creatine is a chemical within the body that helps to feed energy to the muscles. We all have it. It's in every human body. And we excrete that through our kidneys as a metabolite called creatine. And that is what we are testing for when we're looking to see if these specimens have been tampered with or diluted down. It cannot discredit the report, but it can help to, approach it in a more careful aspect to what we're doing. And we can also request retesting and let the patient know, hey, maybe you drank too much water today, your urine looked diluted, let's do some retesting and look at these values again. Our labs are able to process specimen from a screening aspect within 24 to 48 hours. And we're also zeroing in on a 1-week turnaround time for our confirmatory testing to be able to get these quantitative test results turned back to our patients. Next slide, please. Were we able to get Emily back online?
Yes, I'm back. So we had some technical difficulties, but we're going to circle back to our friend Steve and just kind of explore him on a different path. Throughout all of these text bubbles, these are different points of interception that treatment providers, community members, or even partners are able to kind of intercept somebody who's experiencing addiction and connect them with appropriate services. So thinking about his story, after his initial incarceration, he's referred to a local outpatient care before being released. And I think that's the most important thing I want to highlight as well. Circling back to our discussions about that 2-week window being such a high risk time for individuals with substance use disorders re-entering society, it's so important that they're linked to care prior to them being released from incarceration. So Steve's linked to care prior to release from incarceration. He's sent to Brightview. He is seen within 4 hours. He's assessed. He has a care plan. His counselors help him address trauma and grief, while medications we prescribe stabilizes his brain and chemistry, minimizing cravings. He's attending his doctor's appointments, his counseling sessions, weekly group counseling sessions to address his cravings and to assist with accountability. He goes back to working full time, eventually progresses through drug court, graduates, pays off his fines, and has that continuous link to care, and the cycle of addiction is broken. So well, as we close, I definitely wanted to highlight our Ask Nicely feedback system. A few times a year, we do send out these surveys through Ask Nicely, and I can't stress enough how much your feedback is. It's so important. It's so valued. We really appreciate the time you take to collaborate with us, and especially with our justice system partners. It's so important to hear your concerns. If you guys aren't getting the level of collaboration you feel you need, I want to know. So I think it's really helpful if you utilize our Ask Nicely or just reach out to your community outreach manager. More often than not, we can collaborate together to make sure we're advocating for our patients and all of our partners are getting what they need. A few takeaways from our time together today. As we close, I really just want to take a moment to thank you all for the work you do with our patients and for planting the seeds of recovery. I know I say this all the time, but I really do believe that most of our partners see our patients through the most difficult times of their lives. And on the treatment end, we get to see them heal, grow, get jobs, get their kids back, buy a house, and thrive in recovery every day. So truly just thank you for everything you guys are doing to serve our patients, and we truly appreciate your collaboration.
Okay, we've got some great questions from everybody. We're going to jump into those. But first, I just wanted to congratulate Brian Hall. As some of you may have seen in the chat, he was the 35th person in the city of Youngstown, Ohio, to take methadone at a methadone maintenance clinic. He's been free from heroin addiction for 52 years. That's amazing. Congratulations, sir. Jumping into the questions. First one is from Rebecca. I'm wondering what the education for probation officers looks like and how they address mental health emergency recognition, and support for individuals experiencing substance use disorders. Do you have any insights on this?
When it comes to insight on training for probation officers, I'm not too sure exactly what kind of training they have access to, but I can extend an open invitation again. If you are working for a probation department and you have questions, or you'd even like a little bit more in-depth training around addiction, treatment at Brightview, barriers a lot of our recovery or a lot of our patients face in recovery. Your community outreach manager is going to be such a great resource. Reach out to them and they can help set up additional trainings for your departments. We'd love to help.
Okay. Next one is from Paul. When someone tells Brightview that they are being pressured to discontinue MAT by a court or housing provider or other program in the community, does Brightview do any external advocacy with the community program to reduce pressure on its patients? What is the game plan to increase retention in MAT and long-term survival for clients?
John, I think this would be a great one for you if you have any insight.
Yeah, I can take that one, Kevin. So we have encountered this a couple of times, and our strategy is to do outreach and to do some education about what is appropriate for the patient. A lot of times it probably is not appropriate for the patient if it's not ordered by their medical provider to come off of the MAT. Again, I think it's a lot of times it goes back to the stigma and not having the full understanding of how the cycle works and how the MAT works with the patient. But yes, we will do outreach, do some education, and try to let them know that it's against the plan of care for the patient to do that if it's not ordered by the medical provider.
Okay, great. Sandra is wondering, what are your counselors and clinicians' licensing credentials? Are they qualified to diagnose, treat other DSM-5 disorders like personality, depressive, and anxiety disorders?
This is a really great question. And when it comes to specific licensure of our clinical providers, that's going to vary state to state just because there's different boards and different credentials for every state we operate in. Brightview primarily treats substance use disorders. So when it comes to somebody who's experiencing personality disorders, typically, or anything to that extent, typically we work on a dual care plan and we lean on our community partners to kind of help with some of the mental health aspects, and we work on treating substance use disorders.
Okay. Next question is from Jill. What is your experience with behavioral health interventions such as CBT and contingency management? Not in replace of medicated assisted treatment, but as an adjunct and especially at discharge.
This is a great question. I am a huge fan of contingency management. And with CBT, I mean, all of that's pretty much a foundation of clinical care. But circling back to contingency management, this is an intervention that helps to rewire the pleasure and reward pathways that Jenna was talking about, and substitute that from drugs to positive experiences in recovery. So all of our centers have what we would call a reward card. So we did a study a while back, and this kind of informed our Every Visits Counts program. So when patients are engaging in our services, they get a punch card. They're able to fill up this punch card with their groups, individual counseling services, medical visits, and then they can cash those in for small items like gel pens or notebooks, things like that, water bottles, that really just kind of help rewire that pathway in their mind from using illicit substances to reinforcing attendance to group counseling services and being rewarded in that way.
Olivia is wondering if you're not a drug addict and want Narcan as an emergency tool, how would one go about getting it? She lives in Martinsville, Virginia.
Olivia, if you could post your maybe a contact or an email in the chat, I'll reach out to you personally. I'll collaborate with our community outreach manager in Martinsville. When it comes to Narcan resources, there are some national level resources and there's a lot of state level resources. I believe Virginia uses Next Distro, but I'm going to do some digging and get back with you on that. For everybody else that's interested in Narcan, it is usually available in most states through the health department. So you could always circle up with your county's health department to kind of help point you in the right direction as well. Okay,
that's great. We've got one more question, just enough time for it, I believe, from David. When it comes to long-term, lifelong recovery, similar to what Brian Hall has shared with us earlier, how do you connect your clients with these supports?
I think it is really important to have exposure, for our patients to have exposure to individuals who are in different stages of their recovery. So thinking about connecting with somebody who is in long-term recovery, oftentimes that happens in the group room. Right at Brightview, we have groups that some groups are specific to stages of recovery and some are more open for anybody experiencing addiction and getting treatment at Brightview. And some of my favorite interactions as a group counselor was just to sit back and let them talk a little bit, let them encourage each other, and to see somebody who's had a little bit more experience in addiction be a light to somebody else. That's the true gift of recovery right there. We also work to be knowledgeable about our community resources in all the areas we serve through our outreach department and our community outreach managers.